Medication Administration, Part 6, Iowa Lakes Community College. This is Martha Olson. As we look at the parenteral administration, it entails injecting the medication into the body tissues. We have several components revolving around medication administration. It's usually a syringe, an ampule, vial that's needed, and after the medication is prepared, we have to select the most appropriate site needle for that. After the needle pierces the skin, we do have a risk for infection that is possible. With medication administration, our syringes usually are luer lock, which means we have to give it a half turn in order to hold it in place. Non-luer lock means you just kind of tighten it on there. Our sizes are usually 0.5 to 3 mils for our parenteral injections. The 60 milliliters would be used for irrigating wounds or other large volume things that we may need to do. We change the needle sometimes if it's pre-packaged and the syringe is the size we need, but the needle size is not the correct one. On page 601, our types of syringes are listed here. The top one is a 5 milliliter. Next down is 3 milliliter. Then in picture C is our smaller tuberculin, which is 0.01 hundredths for doses less than a mil. Very accurate. And then our last one is the orange cap, a 50 unit insulin syringe because it's in units. The parts of the syringe are the plunger, barrel, and tip. We want to keep the tip and the plunger very clean and sterile. We want to only touch the very end of that plunger where you can see the little handle, and then you measure the dose from where you see the arrow coming out. Fill a syringe by pulling the plunger outward while the needle tip remains immersed in the solution. So if you have a vial upside down, you actually have to pull the needle down lower as your medication is leaving the vial and entering into that syringe. Touch only the outside of the syringe barrel and avoid letting any unsterile object touch the tip because this is a very sterile procedure. Parts of the needle are the bevel, shaft, and gauge, or with the hub. The tip of the needle or bevel is always slanted. That bevel then creates that narrow slit when injected into the tissue that quickly closes when the needle is removed, helping to prevent the leakage of medication, blood, or serum. Long beveled needles are sharper and narrower, minimizing discomfort. And some of the needles are packaged in individual sheaths to allow flexibility in choosing the right size of needle for the patient. Others, again, are pre-attached. When I look at the bevel, we know with intradermal we want that bevel to be up to allow the bleb to form under the skin in giving that intradermal. Our types of needles from top to bottom is a 19 gauge 1.5. That would be appropriate for any IM site below the waist. The next one down is a 20 gauge 1 inch. That would be appropriate for a small person in the vastus lateralis or ventrogluteal site, or in a person that has good muscle mass in the deltoid. The very smallest one then is a 5/8 inch length with a 25 gauge. That's very small and would be used for people that the muscle mass is just directly below the skin. So we choose the needle length according to their size and weight, the type of tissue that the med is going to be injected into. A child or very slender adult may need a much shorter needle. We use the longer 1 to 1.5 inch needle for IM injections. And as the needle gauge becomes smaller, we know the diameter becomes larger. So a 16 gauge is going to be very large. A 23 gauge is going to be very small. In putting the injection units into the carpet jet, these are disposable. Many of them are single dose pre-filled syringes. The outside part that you see him loading it into is reused. It's called a carpet jet. It's got a blue handle that twists on, and we wipe it off with alcohol between patients or left in the med room. If for some reason you put the carpet jet down into the sharps container after administering a medication, you would not go and dig it out. It's about a $5 item, and you would just chalk that up to a good lesson. On the left then you see where they're putting the carpet jet and the pre-filled syringe in the cartridge and assembling it In C, now they're tightening it so that it locks in place both with the blue, and then in the last one they are screwing the plunger into the end of the cartridge so that it can expel the medication as we want. Our medication administration is either in a vial off to the left in picture A. Our vials, or our, excuse me, A is ampules, and they contain single doses. Usually we have to tap with our finger the top of the ampule to get the medication to come down into the glass bottle. We take an alcohol wipe container and put over the top to break it away. You can see where there's a colored ring around the neck that indicates where the ampule is pre-scored, and we break it there away from us. And then in picture B is the vials, and that vial is a single dose or multi-dose that has a rubber seal on top. It protects the medication inside until it's ready to be used. Vials are usually liquid or dry forms of medications, and medications that are unstable in solution are packaged dry, and then we would administer usually normal saline or a sterile distilled water into the vial to activate it, mix it well, and then pull it out into the syringe. Unlike the ampule, the vial is a closed system, so we have to put air in it to permit it to be withdrawn easily. Failure to inject air, so if I'm taking out 1 milliliter of solution, I need to fill it with 1 milliliter of air so that it doesn't create a vacuum within that vial that makes withdrawal of the liquid difficult. Some vials, like I said, contain powder. We mix it with the diluent. Some of them are able to be kept in the refrigerator for a period of time if it's correctly labeled. In looking at our medication administration, if we have two medications that are compatible, we can put those into one injection. A good example is our regular and NPH insulin, so that we limit the amount of injections a person has to receive at one time. When we mix medications from a vial or an ampule, we prepare the medication, trying to not contaminate one medication with another, ensure that the final dose is accurate. If you are drawing out insulin and you have regular and NPH, that nurse that is double checking your medications must watch you draw out the amount of regular to make sure you have the correct amount, and then draw out the NPH that you have the correct amount for a total that is appropriate. As we look at mixing medications, this is on page 603. It's a skill you will practice in the lab. We put the air in vial A, then we put air in vial B, flip the vial over, and pull the amount of medication or insulin that we need out, and then we would pull the medication out of vial A secondly, which already had the air injected into it. The reason that we draw out the regular insulin first is it's clear. Remember, you like clear days better than cloudy days, so we draw out the regular and then the NPH second, and following the guidelines of watching for correct amount. As we prepare insulin, we remember it's a hormone used to treat diabetes. We do not give insulin orally because the GI, the acid in the stomach, breaks down insulin, which is actually a protein, and so we must give it by sub-Q route. They have tried in the past where you have an inhaled insulin, but they found the rates of absorption were variable. If the person had a little bit of a cold, it wouldn't absorb as well, and we're not able to achieve the blood sugar levels that we needed. Remember, with insulin, we always want to use a U100 insulin syringe. Many of the insulins now are in a pen that the person can click, and the insulin is already mixed, so they use the pen to click the amount they need, put a new needle on it, administer. Our insulin is always thought of by rapid, short, intermediate, and long acting. Some of the insulins mix well together. We have some of the insulins that don't, and we have to know so that we never mix insulins that shouldn't be given together. Insulin provides a very safe and effective means of controlling blood sugar. We need to know as nurses the onset, peak, and duration of each type of insulin so we can anticipate when that insulin is working at its hardest, and they might potentially have a hypoglycemic reaction. Some of the insulins come in, again, that pre-mixed solution. If it's a 70-30 insulin, we know 70% of the is NPH and 30% is regular. This helps eliminate the need to mix insulins for many older adults. That's a very cumbersome task and they are not able to complete that. So the pens have been very nice in that they do not have to mix insulins from at home. When we mix insulins, we remember we have to always know what the blood sugar is. A patient with diabetes sometimes requires more insulin. Pardon me. And before drawing up any insulin doses, gently roll the cloudy insulin so that it is ready to go. That's the end.